In 2020, Jamaica recorded 618 new cases of HIV/AIDS. Among the key vulnerable population, youths aged 15 to 24 years accounted for the highest number of new diagnoses. Overall, the parish of St. Catherine was leading the chart for the new cases. St. Anne was next, followed by St. James and Westmoreland. But have there been any strides in the HIV/AIDS fight in Jamaica? And how is the health system handling the demand amid a pandemic? Hello, I'm Damian Mitchell, and thank you for joining us for the Gleaner's Editors Forum. Today, assessing the HIV/AIDS in Jamaica. We're joined by Joan Stephen, a woman living with HIV/AIDS, who works as a community facilitator at the Jamaica Network of Seropositive. That's the national network of people living with HIV. We also have Manuela Manova, UNAIDS Country Director. Alicia Robb Allen is the Acting Senior Director in the HIV Sexually Transmitted Infection Unit of the Ministry of Health. And Candace Livermore, the Executive Director of the Jamaica AIDS Support for Life. So let's begin by allowing our guests 2 minutes to highlight what they see as the major challenges or improvements. Joan Stephen, let's begin with you.
Good morning again. Thank you for having me on your session. What I see as the most challenging is how we deal with individuals who are HIV positive. The discrimination is one of the key factors in society, not only in Jamaica, but globally. And there's a lot more, but as we go along, it will advance more.
Well, thank you very much, Joan. Candace, you have your 2 minutes now, or 120 seconds, you can choose.
Good morning, everyone. So when we talk about challenges, when we look at the HIV response in Jamaica, I think we still have persons who are afraid of HIV. They do not have the correct information, even in this day and age, about HIV, and just taking responsibility for themselves, getting tested. And even when they do get tested and know their diagnosis, there is a sense of denial. So we are seeing where persons are not accessing the treatment services that are very available for them. I could go on and on. I agree with Joan that stigma and discrimination, sometimes when we do the but whys, the whys always lead us right back to why people are not accessing services. And it's just the fear of the stigma and discrimination of persons knowing their status and how people will be treated. But I think we have come a far way as a country in terms of how we're responding to HIV. I think we have seen a sense of partnership that, I think is the hallmark of the response. How government, civil society, or international partners have been able to work together over the years to bring about the required changes that are necessary. We are not necessarily there yet, but I think partnership is what is making the difference right now in the response. Yeah, of course, ensuring that the communities are at the heart of it and they are as much involved as the technical experts. Those things I think are making a difference.
Right, thank you very much. Manuela Manova, UNAIDS Country Director, you have 2 minutes.
Yes. Thanks very much. Well, I think that Jamaica has really made a substantial progress. For me, one of the biggest achievements of the response is the adoption in 2017 of Treat All policy. It means that every Jamaican living with HIV is receiving free of charge from the government of Jamaica antiretroviral treatment. So that's a great achievement, and it is sustainable and is providing the most needed service for all people living with HIV. Connected with this, the other big achievement I would say is that government gradually is increasing its own funding in the response. Well, maybe not with the speed and the proportion that we would like to see, but it is a trend upwards of investing its own resources. And if I have to go about the challenges, I think a big challenge for all of us working in the HIV field is to keep the HIV on the agenda of the, I would say, on the political agenda, in the public space dialogue, because the country is facing so many competing development priorities and emergencies. So that's why this is one. And then for me, another big challenge, I would say, is our coverage of programs. Coverage with prevention services is very low. Also our treatment cascade is below the 2020 targets. And of course, I would say the legal environment, everybody mentioned it. We don't have anti-discrimination legislation. We have very high community stigma and very high self-stigma. And one last challenge for me is our data. Because to make informed evidence-based decision on where our resources need to go, how we design our policies, we need to have a very reliable data. Where is our epidemic coming from? Where are the new infections coming from? What are really the number of people that we are reaching? And once we don't have this reliable data, it can prevent us from taking the efficient and effective decisions for the response. Thank you.
There are many issues to pick up on, among them that of the anti-discrimination legislation. But let's go to Alicia Robb Allen, Acting Senior Director in the HIV STI Unit of the Health Ministry, for your 2 minutes. We'll come back to you in a short while, Ms. Manova.
So I think everybody covered the deficiencies, the challenges that we have faced as the HIV response, as well as the successes. So for me, awareness about HIV, awareness about sexual practices, awareness about the services that are available, especially to our youth, because it obviously has spilled over in 2020 in terms of our 16% of the persons who have been diagnosed with HIV coming from our 15 to 24 population. So I think awareness is where we need to push within our response. Additionally, the knowledge, attitudes, and practice behavior study did show a decline in youth knowledge of HIV, sexual practices, as well as prevention practices in terms of sexual and reproductive health in our youth. So that is something that we need to push as a country so that we can equip our youth to make informed decisions about their sexual practices. So I think that's one. And I'll go to successes. Manuela did speak of Treat All and the government's continued commitment to providing antiretroviral medication for the population of Jamaica. We have not faltered in this, and we have not had a stock out of antiretroviral medication despite the COVID-19 pandemic since 2018. Additionally, we have also been able to increase the number of access points to care for persons living with HIV by six points within the last year. And that was extremely difficult in light of COVID and the decreased access to care. So the Ministry of Health and Wellness has done as a stellar job during the COVID pandemic. And even though we have not reached our targets based on the UNAIDS targets of 90, there has been steady progress in the HIV response.
Well, let me just pick up on a point you made a while ago. So you're saying that the availability of antiretroviral drugs remains high for the people who are living with HIV, but are they coming to collect their medication?
So we have seen an increase in viral suppression, which is indicative of adherence to medication. And we have had an increase in the number of persons added to care. However, we still have to plug a gap in terms of our retention. We still are losing about 900 persons on an annual basis from our treatment sites. And it's for several reasons. People deciding that they don't want to return to care, whether it be as a result of stigma and discrimination, social issues surrounding their lifestyle, or pill burden fatigue, which is something that really a lot of PL-HIV are facing, because taking medication daily for the rest of your life is a mammoth task that some people see as a mammoth task.
Well, we'll come back to some of those issues because the issues are many where that is concerned. But let's go back to Joan Stephen, though. You mentioned earlier, Joan, that discrimination is a big problem for you. How is this manifested?
Well, it mostly manifested in probably how people see you as, because they see HIV as, I don't know, to be honest, I don't know how human beings look at it, but the moment that you mention that a person is HIV positive, it just don't want anything to do with you. It's not everywhere, you understand? It's not like before, but it is still there. And in communities, in most people, sometimes when the individual find out they are HIV positive, mommy doesn't know, nobody in the family doesn't know, in the community doesn't know, because the moment that they found that out, it's an out for you. You cannot be there. I am not hearing what you said.
I'm hearing you. And where are these places? Where are these places you're finding that the discrimination exists most? Is it when you go to pick up your medication? Is it in the community? Is it at church?
It's everywhere. Little of everywhere. A little can be in the church. A little can be at the health sector. It can also little in the community. As I said, it's not as enormous as it used to be before. But most persons who doesn't go for the meds, sometimes we have someone who can go and pick it up for them. Because in most cases, you have people who go and fill prescription for others who are afraid of going into the health sector. But so long as a person doesn't know that they're positive, they're free to come and go as they feel a mind. But once someone aware of the fact that they are, that's a gap right there. You know, they just don't want anything to do with John Public. I have a friend who says her HIV status is going to take her to her grave and no one will ever know because she's not talking, no matter what. So, you know, that's that fear. And I think that fear comes from not accepting, because a lot of people figure more or less that the moment that you found out that they are HIV positive, they don't want anything to do with you. So I don't know. I can give God thanks. I live in a community where everybody knows that I am HIV positive and no one treats me any different. So I don't know if it's the way how you associate yourself with people. I have a lot to do with that. But it's something more that we have to really look into to see what causes it.
And what's the nature of your community? Is it, for example, one of those communities which is more affluent? Is it one of those communities which is in the middle class?
It's affluent. It's not a middle class one, you know. But I think when I did a Susan show once where I speak about my HIV status, and based on that, a lot of people said, "But oh, look, I didn't know you were positive," and I said, "Yes." You know, it's a journey that when I overcome certain of the things, I said, I need to speak about this. People are looking at HIV wrongly. And if I can come out and share my story, probably they might see it differently, you know. So it might reach some, it might not reach some, because it's not everybody watch news or look at what is going on social media. But like how you have the iPhone now where everybody is on that. I think that's where we need to get in more to. You know, for those who are
communication,
right, so they can
communication, right? You're in the right company. We're going to ask Alicia, Rob, Alan a little bit about that in a short while. But let's look at this issue of the statistics. So up to 2020, some 27,297 people living with HIV in Jamaica were aware of their positive status, but an additional 5,000 were walking around unaware that they could be positive. Of how much concern is this, Candace?
As I said, it's one of the areas that we consider a challenging area because, again, we were trying to find 90% of all the persons that we believe are living with HIV, and we believe that the fact that we have gone so far, it's going to become more difficult for us to find that last 5,000. And so the awareness that we're talking about that persons need to take, the personal responsibility, internalizing the messages and understanding that once you're sexually active, you are at risk of contracting HIV, and take on that responsibility to get tested and to know your status. I think persons are kind of running away from that, believing that HIV is not for them, but I know for a fact that no one knows what can happen when we are doing it, and HIV does not discriminate. It is we who discriminate, and so you have to really take charge of your life. Of course, we know that there are some persons who are more vulnerable than others, but what we are getting a sense of, because persons might believe that their vulnerability is not as significant, they are moving away from the fact that they need to take control of their HIV status. That is really a challenge.
Sorry, somebody trying to come in on this?
No, it's okay.
Right, let's home in on this issue of the vulnerable groups, because outside of the fact that the youths aged 15 to 24 are seeing a very significant number of cases, we're also seeing where the prison population in the past 20 or so years has seen almost a tripling of the number of infections. Does this mean that the discussion about condom issuance in prison should resume, Manuela Manova?
Sorry, the condom use in prisons?
Yes.
Of course. I mean, that's a very, condom use is one of the elements of comprehensive prevention programs, and it has to be available, accessible, affordable to any population and any people that are at high risk of HIV infection. So if we have 6.8%, I think, prevalence among incarcerated people, yes. They are at high risk of HIV infection. So condoms should be available to them.
But
and there are many countries, and I would say Muslim countries, like Azerbaijan, and I'm giving this example because I have been working in that region, that have condoms in prisons plus syringes and needles, clean syringes and needles, because in that part of the world, they have a lot of injecting drug use problem. But condoms and these clean syringes and needles are provided in prisons to protect the population from getting infected, yes.
How does this government, though, walk through the politics, if you may, in going back to that issue of issuing condoms in prisons? We know very well the story of the late 1990s when there essentially was a riot because of that.
Is this question to me or to someone?
Yes, that's for you, Manuela.
Well, I prefer to defer this question to some of my colleagues that probably will better respond. I said loud and clear my opinion that it has to be available, and we need to find a way to avoid what has happened, but I really would like my Jamaican colleagues to comment on this, honestly.
Sure. Alicia, I think the ball is in your court.
So there are several legislations that govern our inmates that it doesn't reside in health. That's number one, and it's something that we really should look at. But we also need to look at the prison population, the numbers that have gone into prison who have been positive going in. Is it that they are contracting HIV in the prisons, or is it that our PLHIV are moving into the prison population as it stands? So that is something that we need to interrogate from the Ministry of Health to better understand where exactly we need to plug the gap in terms of, is it that we're looking at condom use or prevention modalities within a prison setting, which would require a legislative move outside of the health setting. But if it is that it needs to be supported and the data points in that direction, it is something that should be considered.
Well, that should be pretty easy, because as part of the general screening, an HIV test is done for new inmates, isn't that so?
Additionally, we have to look at, you bring up a very valid point. In terms of our screening, we have increased our screening in our population, in our prison populations on entry within the last 5 years. So there may also lie the avenue where we are having a higher percentage of persons being picked up for HIV within that setting.
Do you agree that it's time for the discussion on issuing condoms in prisons?
I think a discussion should always be had once we see our data changing, and to ensure that we are serving the population, serving the key and vulnerable populations within the subgroup of our persons living with HIV. So if it is that the data is showing that, it is definitely a discussion that should be resumed.
Candace, should we be moving beyond the discussion to getting it done?
Yeah, there are some things that we're very dispassionate about. You know, we should only be working with the data on some things. And so this issue of the prison population is one that has been a recurring decimal for years and years and years. And we are watching the percentages go up, whether it's because new persons are coming in or people are contracting it. I think we need to move to a place where we can have some policies in place to ensure that everyone's rights to health and safety is guaranteed. Mm-hmm. And if it is that is what we're seeing, we should be putting systems in place to ensure access to persons who need it, because it can't be a good thing to sleep on knowing that there's something that we could have done as policymakers and as officials and government ministers and politicians to really guarantee someone's health, and we don't do it. And so if the data is telling us that we are seeing a rise in this population, then it's a little beyond interrogation, but to come to a decision as to how is it that we're going to make a difference. And then we can do something at the initial stages. And then we talk a little bit more about how to foolproof that. But right now, we continue to dance around those issues.
So is this then on your wish list for 2022?
No, I wouldn't say it's on my wish list. My wish list has everyone, all the vulnerable groups. I really believe that there should be no discrimination as it relates to access to all services. And so for all the populations that are having issues around access, my wish is that we will move beyond our own personal biases and put systems in place that access is guaranteed. That's my wish.
Let's pause here to welcome Christopher Serju, who is on the call, and he has a question. Chris, go ahead.
Muted, Chris.
Ensure you unmute, Chris.
Yes. Among the vulnerable groups such as sex workers, prisoners, and the general population, where are you seeing the greatest rate of increase? And to what do you attribute this?
That's for me.
Yeah, I think Alicia may be able to deal with that.
Yes, but I want to.
So based on our prevalence studies within that were done in 2017, 2018, we're looking at our transgender population as well as our men who have sex with the men as the has population, having the highest prevalence of HIV transmission in those groups. With that being said, or in 2018, we did also have a pop-up group of women who, and we termed them low-risk women because they weren't female sex workers or women who had multiple partners, but were obviously partners of somebody who was positive based on the risk profile of their partner. So Candace brought up a very valid point, access to care. And even though we have our vulnerable groups that have different varying numbers of prevalence, we have to recognize that our population, we have a problem with self-identification. So even though you may be a part of a key population, be a transgender woman or a MSM, you may not identify as that in terms of documentation. And so we're missing a lot of those persons. So they may be grouped in the general population and we're missing them there. So there has to be an overall access to care, and also ensuring that our prevention modalities or outreach modalities are targeted to all populations, but even more so our key populations where we're getting the highest uptake of cases in.
Very well. I want to go back to something that Manuela Manova was raising at the beginning, and that is the absence of legislation against discrimination. Could you paint for us a picture of what exists in other states where this is in operation and what it could mean for Jamaica?
Okay, so the right to health is part either of the Constitution or of any other legislation. And if this is not in specific legislation, then and not only right to health, but protection against any forms of stigma and discrimination based on sex, religion, health status has to be protected in the Constitution or in the subsequent specific legislation. And in Jamaica, unfortunately, the protection of discrimination against people living with HIV based on their HIV status is not part of the Constitution, and there is no general anti-discrimination legislation that would protect not only people living with HIV from stigma and discrimination, but people with disabilities and any other forms. So in a lot of countries, this legislation exists, and it provides a system that protects the right of every person, because the human right is the most important right that every one of us has. And that legislation will protect that human rights to everyone. So we are at the point where, and here is Candace, because the civil society has been extremely active. They have developed a draft anti-discrimination legislation. So now how we move with this, and it's a very, very technical and hard work, which has been spearheaded by the civil society. Now we have this draft anti-discrimination legislation. So how do we move it so that it becomes, and it's tabled in the parliament and is discussed and accepted at the end? And that's some big challenge as well, because so far what has happened is that this legislation, as a draft one, has been presented to the Minister of Justice, to the Minister of Health, and we, Candace can confirm, I don't want to speak on their behalf because they are in the lead of this, we support them, but none of the ministers is willing to take it forward. Let's put it that way. And it's our duty as civil society organizations and as international partners to push forward. And we'll continue. We'll find a way for this to be brought to the attention of the parliamentarians. We'll have to.
Joan, as part of the community, how much do you think this would help?
Well, it would work a lot, but the parliamentarians need to be more involved, a lot more deeper, because at the end of the day, it is health. It's about health. And how do we see the person health? It's not just because you are in a position where probably you can afford to do certain things, but we have to zoom in on the persons who can't. So we need to set up something that, people on our own can really benefit. Because if it wasn't for the NGOs and the private sectors, I don't know where else appeal HIV done today. Because of them who legislate for certain things for us, that is where they are the core. And without them, we wouldn't be anywhere. We'd still be backward in certain things. So I agree with Ms. Manona 100%.
Can we then move the discussion to that of employment for people living with HIV/AIDS, since it's so closely related to that issue of discrimination? Are you finding, Joan, among your peers that people are saying they are losing their jobs simply because they are positive?
Well, I'm not going to say yes or no because I'm not aware of that one. It can be, but I'm not really aware. I want to hear about it 2 times from someone. But a lot of persons who are HIV positive now don't have a job, some of them. There are persons who are HIV positive are working because others don't aware of this fact. So it is not something that is recommended here that you have to do a test. Some people might ask for it, while some don't. But in most cases, there are a lot of individuals who are not working and would like to have a job, but still afraid. What if my employee find out that I am positive? There's this young lady, she had to go to her meds. And I said, why don't you ask your boss for time off? She said, no, they don't know that I'm positive. So I have to wait on my day off. So what happened if the meds, something run out before that? What are you going to do? So, there's so many fear out there. And how do people deal with this? It is inevitable. I don't know. But I try my best, to mitigate something or try to find a meaner way to get things done. Right? So I said, have you ever mentioned to your employee, like, bring up the subject about HIV and see how they respond to it? She said, you must be mad. I love my work and I don't want to lose it. So there has to be where, as I said, use a platform where this is a television where we're sitting down at. It's not just occasionally, but every now and then, bring on somebody like me or anybody else who is willing to speak out, to give people that empathy. But they are human beings, and let us see how they deal with it in a different way. But there must be some way that we can do this to bring people where we really want them to be.
Very well. Candace, can we come back to you on this matter of employment? Are you finding, for example, that there still exists in Jamaica the issue of companies requiring HIV/AIDS tests before employment?
There are still a few companies that do it, and some government entities still do it. I think
government entities
and private entities, yes, because I think for the JCF and the JDF, they still require persons to do a HIV test for employment. We still have some companies that say that because they are in food processing, they have to ask for a HIV test. But I must say it's one area that we have seen some changes. Through partnership over the years with the Ministry of Health, the Labor and Social Security, we would have done a host of sensitization in companies around testing. And I remember when we had to have farm workers had to do a test to be able to go abroad on the farm work program. And we advocated to the Ministry of Labor that was not, it was not conducive to the person's growth and development, plus the persons were healthy and on their meds and doing well. And so I think, and that changed. So I think there is a way for, especially from the technical experts, the scientists need to be more vocal, especially to companies, to explain to them the advancement that the world has made around HIV treatment. I think we're seeing a gap there in terms of what people think HIV is and what living with HIV is, and they don't understand that with the treatment that is now available, you're really just managing a chronic illness, just as you with your diabetes and your hypertension. Sagicor was one company that I have to use this opportunity to say that they, with their life insurance, when representation was made in-house and they looked at it and checked the science, recognized that what they were doing around, access to insurance policies for persons living with HIV was unfounded because of the development in the science. And so we still have people losing their jobs, though. I don't want us to miss that. We still have persons coming to us complaining that once their HIV status became known in their workplace, they either suffer this great discrimination or we even have a case of what we call constructive criticism, where they made the person resign and helped them to resign and write that letter when the person didn't even understand what they were doing. So we still have those cases. But I think in this era of corporate social responsibility, companies, public, private, and third sector need to take responsibility and do more investment in developing policies in their workplaces that affirm people and create space for people and to remove the stigma and discrimination that not just only persons living with HIV face, but other groups that are highly stigmatized. So
is the rationale flawed though? Isn't the rationale flawed of having persons entering a particular employ being required to do HIV/AIDS test?
Very flawed. We call it the nervous chuckle. When you test on entering the workplace, it's not that you're mandating that the person get tested. In HIV, we say you really should test at least once per year. And if you are at high risk, you would test at least twice, sometimes even 4 times a year. So when you do that one test, you're living in Pool's paradise. For whatever reason you think the test will prove to you, because a person remember we have sex every day as people, we are sexual beings. And so your exposure can be any which day you choose, not even choose, it comes upon you. So don't just test at the beginning. In fact, you shouldn't be tested. You should be encouraging your staff to be wholesome and try to be healthy and to take, the necessary precautions, yes, but also to take control of their health on a daily basis.
Which brings me to the question, has there been sufficient agitation for the JDF, the JCF, and the other private entities or the private entities who still employ this practice to desist?
Mr. Mitchell, you're so unkind. For me, from where I sit, and I know I've been a voice out there, I don't think we have been agitating as hard as we should be for the JDF and the JCF, frankly speaking. I think because of the role that these institutions play in society, we kind of, a little coward. But I take a challenge, and I will bring in my CSO colleagues to say it's been a while since we have gone to the JDF and JCF and say, explain this to me one more time, please, to see if there is any merit, because I don't believe that there is any merit. But we will again go seek audience and just saying, look at this opportunity, JDF, JCF, we will be coming to you because we don't think that it's something that really protects the force or the arm.
Very well. We're fast running out of time, and there are 2 issues I want to touch. One of them is that issue of public education, because to a great extent, Alicia, Rob, Allen, there is the feel that the public education in respect of HIV/AIDS has waned over time. What's the plan?
So public education requires funding, and we have been doing public education. I think there was a shift in public education when we had Treat All being implemented to persons living with HIV, and there may have been a small fall off in our prevention voice. But our prevention voice has always been there. I think there has to be a wider conversation in prevention, and not just about condom use, but we have to look at wider sexual practices. We have to enable our youth and empower our youth to be able to make informed decisions. And through the Ministry of Education and Youth, they do have the health and family life education that has started within our schools, but that has to be done on a more tangible and wide-based setting in terms of going to the community. So yes, you're hearing it at schools. Yes, you're hearing it on the media. Yes, you're seeing billboards and you're seeing the buses, but the discussion at the community level needs to be pushed, because we're not just speaking about prevention. We're speaking about stigma and discrimination. We're speaking about disclosure. We're speaking about treatment. There are several arms and issues within the HIV response that need to be passed on to our community, not just our children, not just the persons who can read and write, but everybody along the spectrum. And
I think I may have to disagree with you, though, in respect of hearing and seeing the messages. I don't see that level of emphasis again on the matter of HIV/AIDS prevention and condom use, for example. Am I wrong, Candace? Can we go back to you?
I think you're comparing eras, and you're fair in your stance. The truth is, In years gone by, we had a lot of resources, way more resources available for us to be, for example, every prime time you would be hearing ads around condom use and, HIV awareness. We don't have that level of resources anymore. Plus, there were...
But what we do have are things like social media. The same media on which these group of people, 15 to 24, can very well be targeted and can be reached.
Yes, and I was coming there, and I must tell you, you have to go follow us, Jassel Info on Facebook and on
That's
YouTube
you.
and everything.
That's
yes,
you,
and
though.
I agree.
There's so many other players in this very important event.
We are in agreement. I'm saying there used to be way more players in the HIV response before, way more organizations at the community level, other NGOs were active, and with the drying up of the donor funding, or with the streamlining of the funding, a lot of persons have really closed their whole voice to it. And so we keep saying, we need other partners. HIV has not gone anywhere. We need to still be having the conversations as if we were in the early 2000s. So I would agree that there is a fall off. But the ministry can do what the ministry can do, but I think we need way more persons to get involved. We have to engage more players to be there with us. And we have to use up the social media. We have seen that the use of, and I mean, when I say we, I'm talking about Jamaica AIDS Support for Life. We have ramped up our social media presence, and thanks to COVID brings many things. And, we know the challenges, but it taught us that we had to pivot. And
Ainsley and Anisha.
Yes, Def Ainsley and Anisha. Lord, you're remembering.
Yes.
And so we have used of the social media. The pressure on the faces, though, is something that we have kind of stepped away from because of the realities that people are facing when they put themselves out there. Some persons get it good, some don't get it as good. And so we have not been using many faces, but I can tell you we are very much trying to bring a cohort of persons, train them up, give them the support. We're doing Speakers Bureau to get persons to be comfortable with their diagnosis and willing to share. And so we are asking persons, reach out to us, not just a Jamaica AIDS Support for Life, but there's a Jamaica network of seropositives. We might not be able to come to the Gleaner or to go on TV to talk about it, but persons will come into small groups and disclose and share. And so reach out to the civil society organizations, the NGOs you have out there that are working, and we would be, we are so willing, but there's so much that we can do from where we stand with the resources that we have. So
time is running out on me. Let me ask you this question though. Why has the funding dried up?
Manuela, you want to take that? Well, the truth is we are a middle-income country. When donors come to Jamaica and we are pushing our Benz and Beamers, it shows to them that really, hold on, let us look at the data. But the World Bank says we are a middle-income country based on their assessment. And so the money needs to go to persons who have the greatest need. And so it has it has reduced our funding and shifted the donor funding from the country to other countries that they believe have a greater need. That's primarily the situation. And so there's a push to the government of Jamaica to use its middle income status to make more resources. That's where our voices have been in the last 5 years, looking to Dr. Rob, that the government really needs to use some of its middle income resources and direct some of those funds to the HIV program and what they're doing in terms of HIV investment in the country, not just for their rolling out of their portfolio, but to support civil society organizations to maintain the momentum.
Manuela, can I have you comment on this matter of the drying up of the funds? Is there any light at the end of this tunnel?
Well, the light is that Jamaica is one of the first countries that has started to prepare for transitioning from donor funding. In 2017, a transition readiness assessment has been completed, and in last year, a transition and sustainability draft plan has been developed, which outlines the main risks that the government will face if they do not address this main risk with specific actions, and what this actions and activities will cost, then there will be a disruption in services, and we'll lose the gains that we have through the years achieved with the donor support. So I think that's the light in the tunnel, that the government—
Are you saying though that we are running the risk of having more funds cut?
Yes, we are facing this reality. Well, it will not be coming like in the next 3 to 6 years. That's the horizon that the Global Fund to fight AIDS, tuberculosis, and malaria, that is one of the biggest donor, together with PEPFAR for Jamaica HIV response, has given us this timeline that it will not kind of leave the country in the next 6 years. But after that, we have to really be prepared. And that's why I'm saying that it is very smart of what Jamaica government has started doing. It's not going to happen overnight. That's why it needs this big time span, from 6 to 9 years to prepare and put the systems in place so that the government not only allocates more resources, because it's not only that the government has to put more resources into the budget, but it has to have the mechanisms in place to transfer these own resources to the civil society, to the community organizations. And that's exactly what is happening at the moment. And I just really want to say again that this is one of the steps in a very strategic and positive direction, that the Ministry of Health of Jamaica has announced a pilot of social contracting. Social contracting basically is a term that is used to indicate a mechanism of transferring government resources to non-government actors to perform specific tasks, to deliver specific services that the government wants this partner to deliver, because the government either cannot do this with its own health system or doesn't want to do it. I mean, like reaching the most vulnerable groups, the government health system in most of the cases is not capable to reach to the hardest reach population or not willing to do. And that's the role of the community. And
time is against me, but I'm so fearful that the light we're seeing at the end of the tunnel really is an oncoming train. But let me ask this question though of Dr. Rob Allen. We're looking at the new diagnoses, and we're seeing where this is for 2020. We're seeing where St. Catherine with 134 is leading the chart in respect of new diagnoses for last year. There's also concern in the tourist areas of St. James, St. Anne, and Westmoreland. What's the plan to ramp up public education and intervention in these parishes? St. Catherine, 134 last year, new cases. St. Anne, 81. St. James, 79. Westmoreland, 65. What's the plan to ramp up the level of intervention in these places?
So we are a data-driven ministry, and definitely coming on the heels of this revelation, the prevention arm of the HIV STI response has started their planning in terms of modalities in those parishes that they already are in terms of the prevention teams, to ramp up access to prevention services, and also looking for more, because as much as you speak of St. Catherine and the tourism belt, we have to recognize that St. Catherine sometimes mirrors Kingston and St. Andrew. And we have to look at the fact that Kingston and St. Andrew had 50 for last year. And that is mainly based on a delay in submission of some data based on the ongoing COVID-19 pandemic. But there is a plan in place. There is a push to increase prevention services and outreach services, not just from the government of Jamaica, but with our civil society partners. And as Candace said from the get-go, one thing we have always done well is partnership with our civil society partners and our NGOs. And I do see that we need to get a little better with it amongst our government partners in terms of looking at our stigma and discrimination, our legislation, so that we can move forward as a community to stem the HIV pandemic.
Well, thank you so very much, Dr. Rob Allen. This is where we have to end this segment of our Gleaner Editors Forum today, looking at HIV/AIDS in Jamaica on the occasion of World AIDS Day, December 1. Thanks also to Joan Stephen, a woman living with HIV, who works as a community facilitator at the Jamaica Network of Seropositives, as well as to Manuela Manova, UNAIDS Country Director, and to you, Dr. Alicia Rob Allen of the Ministry of Health, the Acting Senior Director in the HIV/STI unit of the ministry, as well as to Candace Livermore, the Executive Director of the Jamaica AIDS Support for Life. Thanks so much for watching. I'm Damian Mitchell.